All right, good morning. Thanks for coming out so early. We'll see if we can take advantage of the extra 7 minutes. A lot to get through this morning. So we're going to talk about the common presenting features of typical cancers we see in childhood. We're going to recognize some of the common cancer syndromes that might predispose to these. We're going to talk about important prognostic factors in the treatment and outcome of these cancers, common disease and therapeutic complications, and these will be mixed in with some cases. And then we'll go from there. So we'll start off with a case. So this is a 3-year-old, otherwise healthy girl, and she comes in with a 2-week history of worsening abdominal pain and constipation. And the mom says she feels a mass in the belly when she's taken her out of the bath. So this is the x-ray that you get. So a couple of things you can note. So one is she's quite constipated, but then your radiologist tells you also at the lung base on the right, they think they see a pulmonary nodule. So this raises some concern. So you go ahead and get a CAT scan of the abdomen, and you can see there's a, let's see here. All right, there's a very large mass in the left upper abdomen, and you can see the kidneys pushed way down here, and you may get the sense that this mass is kind of coming from the kidney. It's kind of splaying the kidney open. And then on the chest CT, you'll see a number of very large nodules. So the most likely diagnosis in this otherwise healthy girl with a big belly mass near the kidney, this is splenomegaly, lymphoma, rhabdomyosarcoma, Wilms tumor, or neuroblastoma. All right, very good. So Wilms tumor and neuroblastoma are usually the big differentials in these upper quadrant masses, and trying to figure out do they come from the kidney or come from the adrenal gland sometimes can be very difficult. What we saw on the CT scan, so the way this kidney kind of gets splayed open does suggest a little bit that it's coming from the kidney, and then we'll talk about neuroblastoma in just a second. All right, so Wilms tumor, also called nephroblastoma, is the commonest presentation of this, painless abdominal mass in a toddler. And it's the most common malignant renal tumor in children, and you'll see most of the cancers like to be the most common something, so I'll try to point that out. These can be unilateral or also bilateral, so about 10% of them bilateral. They can have abdominal pain, fever, sometimes some hematuria, hypertension, anemia from bleeding into the tumor, and they kind of spread through the lymph nodes. They can get into the blood vessels, and then also the lungs is a common place. So the only thing interesting about staging with Wilms tumor is you can have stage 5 disease, which is very unique for cancers. So if you have bilateral involvement, we call that stage 5. We treat this with chemotherapy, with surgical resection, and then depending on staging, radiation therapy. Poor risk features, so certainly higher stage disease. Under the microscope, some of these are more aggressive. We call those anaplastic. There are certain genetic features that are important, probably more than you need to know. But what's really nice to know is most of these do very well. So even with stage 4 disease, when they are favorable under the microscope, about 80% overall survival, which for any other stage 4 disease is very, very good. Unfortunately, if you're unfavorable under the microscope, many of these patients do poorly, even with limited stage disease. So you have your patient with Wilms tumor. So the question here is, which of these is least likely to have Wilms tumor? So let's recognize the syndrome and which one does not get Wilms tumor. All right, people did pretty good on this one. This one's pretty tricky. So the answer is C, and we'll go through kind of what these patients have here. So the little girl in the upper left has Beckwith-Wiedemann syndrome, and then WAGR or Wagner syndrome. We'll talk about all of these. The boy in the upper right is something called Dennis-Drash syndrome, and they're phenotypically pretty normal on the outside, so that's a normal-looking kid. Hemihypertrophy in the bottom right, and then the girl in the middle has Turner's, which is not a Wilms predisposition syndrome. So Wilms tumors, there's 2 predisposition types. So one is called overgrowth syndrome. So there's parts of your body that are growing more than they should. Beckwith-Wiedemann is probably the one most people think about. But you can also have isolated hemihypertrophy syndromes, which can do this. You saw that big leg in that one patient. A rare disorder called Simpson-Galabi-Bemmel syndrome and Perelman syndrome. There are also non-overgrowth syndromes. So the boy with Wagner syndrome, we're now trying to be a little bit more kind in the description of that. So some people are calling the R, instead of for mental retardation, they're calling it range of developmental abnormalities. But those patients will have Wilms, also aniridia and other GU abnormalities. And then Dennis-Strash syndrome is a congenital nephropathy, but they can also develop Wilms tumor and have some ambiguous genitalia. So in contrast to case 1, we have case 2 here. So this is a 2-year-old, also otherwise healthy patient. Comes in with 2 weeks of being irritable. He's having fevers. He's pale. He's constipated. So it sounds a little bit sicker than the patient in question 1. On exam, he's hypertensive. You also palpate an abdominal mass, and he won't bear weight. And then on his just visual exam, this is what he looks like, and you note this ecchymotic areas around his eyes. So the most likely diagnosis here is leukemia, non-accidental trauma, rhabdomyosarcoma, neuroblastoma, or Wilms tumor. All right, so great job. So this is neuroblastoma. So neuroblastomas, this is a cancer derived from primordial neural crest cells. These form the sympathetic chains in the adrenal medulla. This is, of note, the commonest cancer in infants. Fortunately, most of them will do well. The presentation typically is in toddlers, however, so common in infants, but we see more symptomatic disease in toddlers. And nearly 100% of patients will have had this by adolescence, so it's very rare to see in adults. The location, so the adrenal gland is the most common, and that's why when they're very big, it's hard to tell, is this truly neuroblastoma or could this be a Wilms tumor? But you can also see it other places along the sympathetic chain, so thoracic areas, cervical area, paraspinal primaries are all seen. And then this spreads to many different places. We see it in the bone cortex, we see it in the bone marrow, it can go to the skin and liver, we'll talk about that in a minute, and also through the lymphatics. So a lot of different things can bring neuroblastoma to attention. Sometimes it's because the abdominal mass is so big. This may be abdominal pain. When it's a cervical or thoracic mass, you may get SVC syndrome. The cervical ones, again, can cause Horner syndrome. You might get spinal cord compression. They can have symptoms of metastatic disease because many are metastatic at diagnosis. So the bone pain and limp is probably bony metastatic disease. They may have cytopenias similar to leukemia, so that is in the differential. The raccoon's eyes we saw in the picture is common from orbital infiltration. In infants, this is one of the causes of a neonatal blueberry muffin rash. And again, also in infants, you might get diffuse hepatic spread and cause a big liver. And then these patients are often really just sick looking. They're febrile, they're irritable. They may have diarrhea, weight loss, high blood pressure. And then occasionally we see a really unique paraneoplastic syndrome called opsoclonus myoclonus ataxia syndrome that may present with these. So when we work these up, we can monitor a tumor marker for this. So these tumors produce catecholamine metabolites, so HVA and VMA. We can check those in the urine. And then also because these are metabolically active, we can do special scanning for this. So this is the MIBG scan, which is reasonably specific for neurogenic tumors. And in kids, neuroblastoma is the most common one of those. So treatment's very risk adapted. So there are some patients that will do incredibly well and some patients that will do incredibly poorly, and we try to target how intense our therapy is going to be based on that. So some patients are very low risk. So in infants with limited stage disease, these may resolve spontaneously. And so because we talked about this may be the most common tumor in infants, many of those disappear throughout life. We may never know about them when they're very small. Infants also can have this 4S presentation. So this is where you've got limited amounts of metastatic disease in children who are under a year of age. So you can have metastatic disease to the skin, metastatic disease to the liver, and a little bit to the bone marrow. And when it's just in those places, again, can completely resolve with no therapy. In kids that are a little bit older and kids that have bulkier disease, this becomes a different story. In which case surgery, chemotherapy, radiation, and even giving high-dose chemotherapy, stem cell transplants, and just approved in the past couple of years has been immunotherapy for this that we use for very different therapy. So for this patient, you give high-dose chemotherapy with cyclophosphamide, and what side effects should this patient be closely observed for? Can they get peripheral neuropathy? Can they get hearing loss? Hypernatremia, diarrhea, or hemorrhagic cystitis? So which is a common problem with cyclophosphamide? Very good. So hemorrhagic cystitis is the correct answer. The other ones are not major problems with cyclophosphamide. So again, poor risk features for neuroblastoma, and unfortunately we see many of these. So age over 18 months, there's a gene called MYC-N, which is a cell cycle regulator, and that can become massively amplified or copied in the genome. And so when we see that, that is a poor prognostic finding. Under the microscope, these can have poor findings. And then again, high stage disease is typically poor, except that 4S stage that we see really just in infants. For kids who are younger, who have limited stage disease, the outcomes can be very, very good, most kids surviving. That changes significantly when kids are older, when they have that MYC-N amplification, and then we get somewhere in the 50-ish% range survival, even with very intensive therapy. A couple kids are predisposed to this, so patients with NF1 have a higher risk. And then there's a weird subset of disorders called neurocrystopathies, or these are neural crest cell migration disorders. So the congenital central hypoventilation syndrome, or Andy's curse, is one of these. So if you have a patient with that, they may get neuroblastoma. Hirschsprung's disease is one, and so there is an increased risk of this in patients with Hirschsprung's. And then separate from those is there are familial cases as well with this ALK gene mutation, which is very rare. All right, so our next case, this is a 3-year-old, otherwise healthy girl. She has a 1-month history of abdominal pain and distension, so all kind of similar presentations. Her pediatrician felt an abdominal mass and got an ultrasound. On the ultrasound, there's a large mass in the liver. So the most likely diagnosis for this liver mass in a toddler is rhabdomyosarcoma, hepatoblastoma, hepatocellular carcinoma, teratoma, or lymphoma. All right, excellent. You guys are doing a great job. So this is hepatoblastoma. So in that patient with hepatoblastoma, what's the most likely tumor marker to be elevated? AFP, beta HCG, CA125, CEA, or PSA? All right, also pretty good. So this is AFP. So pediatric liver tumors are not very common. They make up 1% to 2% of all cancers we see in childhood. Hepatoblastoma is certainly the most common of those, and it's more than 2/3 of pediatric liver tumors. And the age is typically pretty young, under 5 years. These are developmental tumors. Hepatocellular carcinoma, in contrast, so we see this more commonly in Asia and Africa. This is probably related to chronic hepatitis B infection. It's one of the reasons we give the hepatitis B vaccine at birth, is trying to prevent not the actual disease, but it's hepatocellular carcinoma later in life. And those patients are typically older, so over 10 years of age. The most common presentation for hepatoblastoma is abdominal mass. Because it gets so big, it might cause pain or anorexia, vomiting. You may get obstruction, cause jaundice and icterus. And AFP, importantly, is elevated in about 90% of these. And it's actually a really poor prognostic finding when it's not. So chemotherapy and surgery, like most of our solid tumors, is the mainstay of therapy. And sometimes surgery is really not possible by itself, and so this may be an indication to do a liver transplant in order to cure this disease. The poor risk features, again, if this is spread, if it's not resectable, again, if that AFP is low, it is a poor prognostic finding. And then again, there are histologic things that pathologists can tell us under the microscope. For patients where this hasn't spread, 75% overall survival, so not too bad. And then again, if it is metastatic, that drops significantly. Predisposition syndromes for this, Beckwith-Wiedemann again comes up here as an overgrowth syndrome. Familial adenomatous polyposis syndrome, or FAP. Patients who have type 1 glycogen storage disease, or von Gerke's disease. So interestingly, I don't know if you've had a metabolic talk yet, but as we have better therapies for GSD, we actually see much less hepatoblastoma because of that now. And then patients who are premature and low birth weight also are at a high risk for this. So case number 4, so this is a 2-year-old, otherwise healthy girl, and she comes to the emergency room, and her mother said she found blood and some tissue in her underwear. This is her exam, and you can see there's kind of a polypoid mass coming out of the introitus. So the most likely diagnosis here, this is abuse, this is vaginal prolapse, sacrococcygeal teratoma, rhabdomyosarcoma, or lymphoma. All right, great. So this is D, Rhabdomyosarcoma. So sarcomas are cancers derived from embryonal mesoderm. The histology doesn't necessarily reflect the tissue of origin. So you can get sarcomas, that have a name that sounds like they should be somewhere, but they're somewhere else. So the other ones besides the rhabdomyosarcoma, there's osteosarcoma, synovial sarcoma, and we'll talk about these. So rhabdomyosarcoma, so it's claim to fame, so it's the most common pediatric soft tissue sarcoma. It's the third most common extracranial solid tumor in children, so that's following neuroblastoma and Wilms tumor. This can come in a lot of different places. Importantly, when the primary is in the head and neck and parts of the GU tract, these potentially can be good places. When they happen in the extremities, that's a particularly bad place to have it. But those are the more common primary sites. This spreads all over. It can go to the lungs, importantly, the bone marrow, bone, and lymph nodes. And again, under the microscope, there's a kind called embryonal that is a good thing to have, and then there's alveolar, which is generally a bad thing to have. So treatment, again, chemosurgery, and then radiation therapy are all very important. Things that make this poor risk, so older kids over 10 years of age, if you have that alveolar type, the primary site, so the orbit and the non-bladder and prostate GU tract are good places to have it. Anywhere else is pretty much not. And then certainly if this is metastasized, is a bad thing. Outcomes, if you have low-risk disease, if it's a favorable site, it's the embryonal type, you get a good resection, you get chemotherapy. Many of those patients do very well. And patients who have metastatic disease or the alveolar types usually do poorly. The one predisposition syndrome to keep in mind is Li-Fraumeni syndrome, which will cause a lot of different cancers, but this is one. And that's the germline P53 mutation. So your next case is a 15-year-old boy that comes in. He's otherwise healthy, common theme. 2-month history of knee swelling and pain. He says he heard it in basketball at the time, and then it just never got better. So he doesn't have any fevers, no systemic complaints. So you get an x-ray, and you notice some irregularity down in the distal femur here. And so you follow that up with an MRI, and of course you notice a large mass in the distal femur. So the most likely diagnosis for a distal femur mass in a 15-year-old otherwise healthy boy: lymphoma, osteomyelitis, aneurysmal bone cyst, rhabdomyosarcoma, or osteosarcoma. Excellent job. This is osteosarcoma. So osteosarcoma usually presents with pain. There may or may not be a palpable mass or a perceived mass by the patient. And it usually happens over several months, so it shouldn't be something that's been there for a week. They may have a pathologic fracture at the time of presentation. That may be the presenting finding. Boys a little bit more than girls, and this tends to happen right around peak growth spurt ages, so right about 15. It spreads typically to the lungs and then also to other bones. And there are a couple common places for this. So the distal femur is by far the most common, and then proximal tibia, so in general around the knee, is a common place. And then third most common is the proximal humerus. But really any bone in the body could be potentially affected. Treatment is chemotherapy and aggressive surgery. So the kind of classic surgery for this was an amputation. With improved surgical techniques, we now do, for the most part, something called a limb-sparing surgery, where the surgeons can, resect, this huge tumor and then reconstruct the extremity to be somewhat functional, certainly cosmetically better. So we see less and less amputation now. Importantly for this, it does not respond well to radiation, so that's usually not a mainstay of therapy in these patients. So this patient is given cisplatin, which is a common part of their chemotherapy, which is not a common complication of cisplatin. So this could be hearing loss, kidney injury, hypothyroidism, severe nausea and vomiting, or hypomagnesemia, what is not common. All right, very good. Hypothyroidism. So hearing loss is common. Acute kidney injury is common. This is the most emetogenic chemo that we can give. So nausea and vomiting is very common. And then it does cause electrolyte wasting in the urine. So hypomagnesemia is also very common. All right. So poor risk features for osteosarcoma, like the other ones, if they're metastatic, is not good. If they don't respond well to neoadjuvant chemo, so we give chemo first, then we do surgery. And at the time of surgery, we can actually see how they respond. So in patients who aren't responding to chemotherapy do poorly. And then if you're not able to get a complete resection, those patients also do poorly. And then the graphs here kind of just compare on the left patients who are non-metastatic who do reasonably well versus patients who are metastatic at diagnosis who do reasonably poorly. There are a few predispositions for osteosarcoma. In real life, we don't encounter them too much. Ionizing radiation, if you happen to be near a nuclear accident, could be a reason to get this. For patients who have other radiation for other cancers may get this. If you have a hereditary predisposition to retinoblastoma, we'll talk about that in a bit, the RB1 mutation, germline, those patients are at risk for osteosarcoma. Again, the Li-Fraumeni syndrome, and then most other things for adults that we really rarely encounter in kids. In contrast to that, Ewing sarcoma is another bony tumor we come across. It's the second most common bone tumor in children behind osteo. And what's interesting is they may have extra osseous, extra bony presentations in the soft tissues. This is typically a disease of the young, so 80% of these are less than 20 years old, so rarely do we see it in adults. The lower extremity is the most common, but we also typically see other axial locations, so you can see the pelvic bones or the ribs or vertebra can be affected. These patients may have systemic symptoms. They might have fever, weight loss, and then about 20 of them will have spread, which is really unfortunate, but they'll go to the lungs, bone, and bone marrow. Chemotherapy, surgical resection, and then in contrast to osteosarcoma, these are very radiation sensitive, and so that's often a key feature of their therapy. Again, if they're metastatic, and then if you have these tumors in places you can't resect them easily, like the pelvis, or if you have a very large primary, those patients also tend to have an inferior survival. Again, if you're not metastatic, you often will do very well. If you're metastatic, there's less than a 25% overall survival. Predisposition, so really we don't see much for Ewing, so there's no common genetic associations. There is a common genetic translocation in patients who have Ewing's just in their tumor cells, but that seems to be the only feature for most of those patients. And then for whatever reason, this seems to have a very low incidence in Black and Asian children, and I'm not sure anybody really knows why. All right, so your next case here, so this is a 14-year-old otherwise healthy boy, and he's had headaches for a month. And in the past week, he wakes up in the early morning with a severe headache, he throws up, and he feels better. He started to see double, and so you very appropriately get an MRI of his brain, and there appears to be a mass in the fourth ventricle. So with the fourth ventricular mass, the most likely diagnosis is brainstem glioma, optic glioma, melanoma, ependymoma, or medulloblastoma. All right, so this is medulloblastoma. So we'll talk about this for a bit. So brain tumors, in aggregate, are the second most common malignancies after acute lymphoblastic leukemia in childhood. The symptoms are based on where these tumors happen, so they can have many different presentations. Headache, nausea, vomiting, often from increased intracranial pressure. You can have ataxia and diplopia, which may be nerve involvement, but may also be increased intracranial pressure. Frontal lobe disease, you may get behavior change or developmental delays. When they have cortical locations, you may see seizures. And then especially if they affect the pituitary gland, endocrinopathies. So gliomas are kind of a grab bag term for many of these. It just means it's a tumor derived from glial supportive tissue in the brain, not from neuronal tissue. This is about 60 to 70% of childhood CNS tumors. Most of them are astrocytomas, coming from astrocytes. And there's two basic categories of these, low grade and high grade. Low grade ones generally do pretty well. These are often chronic diseases, but depending on where they are, can cause a lot of symptoms. So if these occur in a place where you can't do operations, these patients can have a severely disabled life. High-grade tumors, in contrast, so glioblastoma multiforme, or GBM, is the most well-known of those, generally do not do very well. with survivals that are really within 1 to 2 years. They pass away very quickly. Combination of surgery, radiation, and chemotherapy are the mainstay of these. When gliomas occur in the optic nerve or the optic tract pathways, about 70% of those patients will have an NF1 mutation. So it's rare that we see non-NF patients with optic gliomas. And then if you have tuberous sclerosis, is a very specific tumor you get in your brain called subependymal giant cell astrocytoma, or SEGA. When these gliomas occur in the brainstem, it's about 15% of CNS tumors in children. The median age is around 6 or 7, and half of these present with cranial nerve findings or long tract signs on exam. Because of the location in the brainstem, most of these are inoperable, which makes them, of course, very difficult to deal with. They really have a dismal prognosis. It's probably one of the most feared diagnoses in the oncology clinic because there's very little we can do. Typically, we'll radiate them, but they tend to recur within months after radiation. So then the patient in our case had medulloblastoma. So of all the different specific types, medulloblastoma is the most common one in kids. 80% of these will occur within less than 15 years. The posterior fossa is the most common location for these. And so when tumors metastasize, when they're CNS tumors, they tend to metastasize to other parts of the brain and spine. But the medullos sometimes can get out of the neural system, and so they can go to the bone or bone marrow, liver, very rarely. And then there are a couple syndromes to know about. So Turcot syndrome, where you get osteomas in these tumors, and then Gorlin syndrome, where you may also get basal cell carcinoma. And then ependymoma, so this is about 9% of tumors in children in the CNS. The fourth ventricle is also common, but it can also be supratentorial. In our case, because the most likely thing by just pure numbers is medulloblastoma, that's why that was a better answer than ependymoma. And they usually present with obstructive hydrocephalus. Craniopharyngioma, so these are very unique. So these are, quote-unquote benign tumors. These happen as a developmental anomaly in Rathke's pouch, which kind of turns into your pituitary gland during fetal development. The peak age is 5 to 10 years, and because of the location, causes increased intracranial pressure. Because it's near the optic pathways, you get visual loss. Because it involves the pituitary gland, you have endocrinopathies. So usually that kind of, all those symptoms together points you in this direction. The best therapy here is really complete excision. It doesn't respond well to almost anything else we do. And these can be very frustrating because doing surgery in that part of the brain is really very difficult. And then when you do remove them, often you leave them with a lot of endocrine problems. Panhypopituitarism is very common in these patients. And then we'll lump into the CNS tumors retinoblastoma. So these usually present with leukocoria, a white pupil. But if untreated, it can become very large. You can have a proptotic eye. You can have swelling around the orbit. In the tumor cell, at least, you see mutations in the RB1 gene. But if you have a germline mutation in that gene, you might get bilateral disease. So this is from medical school. If you remember Knudsen's two-hit hypothesis, so you have a germline mutation in one of the RB1 genes, and then you acquire over time a mutation in the second one. And so if you have bilateral disease, those patients almost always have germline mutations. And what's interesting is you can also have retinoblastoma in the pineal glands. We call these pineoblastomas. And if you have bilateral retinoblastoma plus a pineoblastoma, you're trilateral. So we always go looking for that with an MRI of the brain. And then again, as we mentioned before, these patients with RB1 gene mutations, germline may be at increased risk for osteosarcomas. So again, there's your leukocoria in the child's left eye. And now that everybody's got cell phones and taking pictures all the time, parents will often show up with the picture on their phone that they can show you. And there's now even an app you can download that'll automatically analyze your kids' photos to look for leukocoria. It's pretty cool. So unilateral disease, about 60% of patients. They usually present somewhere between 2 and 3 years of age. And so if you have just one side involved and they're already over 2, the chance of them being germline mutations is pretty low. In contrast to that bilateral disease, about 40% of patients. Again, most of those will have germline mutations in the RB1 gene. It's not necessarily hereditary, so 85% of those mutations are actually de novo, and then 15% can be inherited in an autosomal dominant fashion. So certainly if you have a parent who has a germline mutation, we are very nervous about the children. The bilateral patients usually present under a year of age, but not always. And then again, they have a high risk of secondary cancers, especially osteosarcoma. Treatment is local therapies and limited disease, so we can use little things to freeze them or zap them with a laser. Sometimes you can put tiny little plaques for radiation therapy just to the tumor, into the eye. When the disease is more extensive and the vision has already been lost, when there's retinal detachment, enucleation is really the only option. Really what gets sometimes very difficult is you don't want to enucleate two eyes. So when there is bilateral disease, we really try very hard to salvage at least one of those eyes to preserve vision for the patients. Chemotherapy we use as an adjunct or in patients who have certain high-risk features. And in the developed world, survival for retinoblastoma is excellent. We almost never see extraocular spread because it comes to medical attention much, much earlier than that. So most of the time, our goal is really maximum vision preservation. Very different than in the third world where these may progress very large before they come to medical attention, in which case these could become life-threatening. So our next case is a 6-year-old, otherwise healthy girl, and she comes to the ER. She's tired. She was very excited to get her ears pierced, but then they seem like they got infected with cellulitis, and she's got a fever of 103. Her exam otherwise is pretty unremarkable. Her white count's high, it's 37.5. Her hemoglobin's low at 8.6. Her platelets are 82,000. On the differential, she has no neutrophils. Her lymphocytes are 55%, and she has 35% blasts. So what does she have? Aplastic anemia, acute leukemia, viral infection, Kostman syndrome, or JIA? All right, very good. So this is acute leukemia. Blasts on a peripheral smear are almost never normal, and when you have that many along with other cytopenias, it's really case-defining for leukemia. So there's two major types of acute leukemia that we'll see in kids. One is ALL, one is AML. ALL is the most common malignancy in childhood. We see almost 5,000 new cases a year in the U.S. The peak age is 2 to 5 years in boys, a little bit more than girls. I like to think about this as the leukemic triad, so fever, pallor, and bruising, and it reflects the fact that you've got dysfunction in all three major cell lines. So you have white cell dysfunction causing fever, pallor because you're anemic, and bruising because you're thrombocytopenic. Because of marrow expansion from this, patients often have bone pains and limps. You may see hepatosplenomegaly from organ involvement by leukemia. In the T lymphoblastic type, T for thymus, those abnormal T cells may aggregate in the thymus, and so you have a mediastinal mass. And then there are variable degrees of anemia, thrombocytopenia, because of the effacement of the bone marrow by leukemia cells. The white count can be quite variable, so it's usually high with circulating blasts, but sometimes it's low, and actually had a patient just like that on Monday. Pre-B cell, so like your B lymphocytes, so the pre-B cell is the most common type we see, and then the T cell phenotype is the other one, and that's more in adolescence. In the B cell type, there's a standard risk stratification from the National Cancer Institute that we still use. It's been around for a long time. It's reasonably simple, so you have to have the B type, your age is between 1 and less than 10 years, and your white count has to be under 50,000. So if you fit that category, we call you standard risk, which is a good thing. If you're outside of that, you fall into a high risk category. These patients have we know a lot about the genetics of ALL, and so there are some things that tell us they're going to do very well. So the most common genetic changes in the cancer cells is a mutation called ETV6 RUNX1. About 25% of patients will have this. It's a very good prognostic feature. You may see duplications of chromosomes 4 and 10, which is good, and you may see just a general increase in the number of chromosomes in these cells. So when you have a lot of them, we call it hyperdiploidy. Those patients also do well. There are some things that are very poor, so translocations involving a gene called MLL, which is on 11q23, do poorly. We often see that in infant ALL presentations. When you don't have enough chromosomes, you do poorly. You could have a common translocation called the Philadelphia chromosome that you remember from chronic myelogenous leukemia, but it happens in ALL as well. And then there's a lot of knowledge now about response to induction therapy. So if you respond well to induction therapy, generally you do well. If you don't, outcomes tend to be worse. And now we can also measure induction response using a test called MRD, or minimal residual disease, to really refine minimal amounts of residual leukemia that is prognostically important. So treatment really is chemotherapy. CNS involvement, so these leukemic blasts can get into the spinal fluid. We treat and prevent that by giving lots of spinal taps with chemotherapy straight to the spinal fluid called intrathecal chemotherapy. Occasionally we'll give radiation to the brain to get rid of those. And what's really been shown to be very important in ALL is a long maintenance therapy. And so we treat these patients for years with kind of low-dose outpatient chemotherapy. Currently, girls get 2.5 years of therapy, boys get 3.5 years, the reason being that boys have a predisposition to relapse in the testicles, and it's thought that extra year of therapy may help that from happening. That is less clear now. In patients who have high-risk disease or cases that don't respond well to chemotherapy, this may need a bone marrow transplant. We now also have very targeted drugs that work on just certain types of these ALLs, and then there's emerging immune therapies. Actually, the FDA yesterday granted approval for the first ever chimeric antigen receptor T-cell therapy. So this is a genetically modified T-cells from the patient that you can infuse back into them to attack their cancer cells. It's absolutely groundbreaking. Patterns of relapse here, so they can, when it comes back, it can come back in the bone marrow. It can also come back outside the bone marrow, so that's usually in the spinal fluid or the testes in boys. There are a couple things that predispose you to this. Most patients, however, don't have a predisposition. The one that you should know definitely is trisomy 21 or Down syndrome. They're 20 times more likely to have leukemia than the general population. Most of it's acute lymphoblastic, but when kids are younger, it can also be AML. Patients with Fanconi syndrome or Bloom syndrome, which are is a DNA repair problem, can have this, but more AML. And then ataxia telangiectasia, which is an immune deficiency disorder. In contrast to ALL, we have AML. So this is acute myeloid leukemia. The incidence is reasonably constant throughout life. There's a little bit of a peak in the neonatal and young infant period and also in adolescence. There's kind of, if you remember from medical school, this FAB classification with these M staging numbers, M0 through M7. Most of them don't matter for you all. There are a couple that are a little more specific. So if you have the promyelocytic kind, it's M3. There's a translocation with the retinoic acid receptor. These patients often present in DIC. And we'll talk about why that translocation is important in a second. And then in Down syndrome, they almost always present with the M7 or megakaryobllastic type. So actually, when you look at the smear, their blast cells look a little bit like platelet precursors. There are also some genetic features in AML. I doubt these will be testable for you. That said, inversion 16 or translocation on chromosome 16 tend to be pretty common. As good ones, there's an 821 translocation that is good, and we'll talk about the retinoic acid receptor in a second. There are some poor risk cytogenetic features. So if you get AML because you had prior cancer and had chemotherapy, that's really bad. Monosomy 5 and 7 are bad. Complex karyotypes, this thing called FLT3, internal tandem duplication. And then just like in ALL, if you give chemotherapy and you don't get better quickly, it's a bad thing. So chemotherapy is really intensive. It's done almost entirely inpatient. These patients are always sick. They're always in the hospital. They have infections, they have mucositis, they bleed, they have lots of transfusion burdens, they may be on TPN. What's very different, though, are these patients with the promyelocytic type, that 15-17 retinoic acid receptor translocation. So in these patients, if you give a differentiation agent, so retinoic acid, along with arsenic, you can often cure these patients with no actual chemotherapy and very little toxicity. So if you have to have AML, it's probably the one you want, because those patients universally do quite well. When patients with AML relapse, or if they have high-risk features at the beginning, we often will do a bone marrow transplant for those patients, much more common than in ALL. Many more predisposition syndromes, and if you think about it, these are mostly immune deficiency type disorders or something else that's going on in the bone marrow already. So we have Down syndrome, Fanconi anemia, Kosman syndrome, which is severe congenital neutropenia, Bloom syndrome, Diamond-Blackfan, and then again, if you have had chemotherapy, that can trigger an AML. So a 7-year-old girl comes in. She's been coughing for 2 months. She now has dyspnea and she has orthopnea. And you get a chest x-ray, and you very astutely notice that the mediastinum here looks pretty wide. So you send her to get a CAT scan to see what's going on. So the heart is down here, and you can see it's kind of smushed under this mass-like lesion that seems like it should be where the thymus is supposed to be. So the most common diagnosis here with this mediastinal mass, this is a bronchogenic cyst, a neuroblastoma, a lymphoma, a Ewing sarcoma, or inflammatory myoblastic tumor. All right, very good. This is a lymphoma. So mediastinal masses, there's lots of things that can do this. The mediastinum you can think about as an anterior and posterior mediastinum. The lymphomas and germ cell tumors, when they present in the mediastinum, tend to be anterior. And the posterior, we think about neurogenic tumors. That's where your neuroblastoma might come, or a Ewing sarcoma or rhabdo. Lymphoma classifications are a little weird. A lot of people think about Hodgkin's and non-Hodgkin's, which is true. Non-Hodgkin's also being a grab bag term. There's lots of different types. In kids, we tend to see the more aggressive ones. So there's a lymphoblastic type, like a T cell. And then we call it mature aggressive B cell lymphoma. So this is Burkitt lymphoma or diffuse large B cell. There are a lot of other indolent chronic lymphomas, tend to be more in adults. Lots of things can cause adenopathy. So you'll hear from many different people about things that cause swollen lymph nodes. So it doesn't always have to be cancer. So Hodgkin's, so typically this is painless lymphadenopathy. Cervical, supraclavicular, axillary are pretty common. Mediastinal mass is pretty common. Tends to be a subacute presentation over weeks to months. Tends to be teens, young adults most commonly. Some of these patients will have what we call B symptoms. So this is fever, weight loss, and drenching night sweats. They may be lymphopenic, they may have eosinophilia. The sedimentation rate's often quite high. It's a prognostic finding. And it tends to spread through lymphatic channels in kind of a regular progression. So it starts in one place and you can kind of just, if you didn't do anything, you can kind of watch it marching its way through the lymphatic system. It may spread to other places. The spleen is a common place to go, or the bone marrow. Poor risk features, so if they're higher stage disease, meaning both sides of the diaphragm, or widely metastatic to other organs, B symptoms, and if you've got just really big tumors, we call bulky tumors, increase your risk. You want to try to excise them if you can, otherwise chemotherapy and radiation are really the mainstays. And so complete excision is almost never done for most of these. The prognosis, so if you took all patients with Hodgkin's disease, more than a 90% overall survival. So in general, this is a pretty curable problem. The problem is that the therapy can be sometimes intense with a lot of long-term side effects. And so one of the things we're really focusing on right now in Hodgkin's is how do we cure this without so many side effects later in life? This probably has some of the biggest burden of late effects of anything we treat. So because of radiation therapy, many patients become hypothyroid because you're radiating their neck. They have cardiomyopathy from anthracycline chemotherapy, from chest radiation. Chemotherapy like etoposide especially leads to secondary myeloid leukemias. Radiation therapy can lead to secondary cancers. And then many of these patients have poor splenic function, or we've even done a splenectomy on them. And so late post-splenectomy sepsis is also seen. But for this patient, prior to starting therapy for Hodgkin's, and they have bulky adenopathy, this boy develops plethora. He has an engorged neck veins, he's wheezing, he's dyspneic. Immediate management should not include what? So supine positioning, IV fluid, supplemental oxygen, a chest x-ray, or avoiding sedation. What do you not want to do? All right, very good. You don't want to put them supine, right? So with a big mediastinal mass, you put them supine, it obstructs the airways, it obstructs the mediastinal vasculature. So in terms of non-Hodgkin's lymphoma, so a lot of these are, so there's lymphoblastic types, so most of those are T lymphoblastic lymphoma, and it's kind of on a spectrum with T lymphoblastic leukemia, so mostly the same disease, just depends on where the tumor cells are. These are typically adolescents, and they have an anterior mediastinal mass. Then on top of that, there are these aggressive mature B-cell lymphomas. Burkitt's is kind of the more classical one. It's got the 814 translocation in c-Myc. Its claim to fame, it's the fastest growing tumor on the planet. It doubles about every 24 hours. So when you're trying to figure out what's going on with these patients in the hospital, you'll watch the lymph nodes just like grow in front of your eyes. There's an endemic or African variant, typically a jaw primary, which of course we don't see much in the US. It's associated with EBV infection. And then in the US, more commonly the sporadic types, you see ileocecal primary. So they sometimes present like an appendicitis, and then you find the mass. So predisposition, again, immune deficiency disorders tend to be pretty common. So Wiskott-Aldrich syndrome, SCID, X-linked A-gamma-globulinemia, or Bruton's, common variable immune deficiency, ataxia-telangiectasia, and there's this weird lymphoproliferative problem called autoimmune lymphoproliferative syndrome, or ALPS. Again, we see rarely, but patients with HIV, this can be an AIDS-defining condition. And then in patients who have had organ transplants, whether it's solid organ or bone marrow transplant, can develop lymphomas because of the immune dysregulation after a transplant. So our final question here, so 8 hours after starting chemotherapy for a bulky abdominal Burkitt lymphoma, a 13-year-old boy gets oliguria, and which lab profile is most consistent with this complication? So we've got varying potassiums, phosphates, and uric acids. We'll see how we do here. Well, not bad. All right, good job, guys. So this is the tumor lysis syndrome. So we see with that increased potassium, phosphate, and uric acid. So in non-Hodgkin's lymphomas, surgery really only if you can completely resect them. Chemotherapy is a mainstay, radiation in select situations. And then generally, children do pretty good. Tumor lysis syndrome is often seen in the setting of these aggressive tumors because the chemotherapy breaks the cells down so quickly. You get release of intracellular products into the blood. And so the mainstay there is hyperkalemia, hyperphosphatemia, hyperuricemia, and then calcium can be a little weird, but often hypocalcemia, so it kind of binds to the phosphate and goes down. For TLS treatment, we give hydration. You may need to make them pee more. We used to give alkalinization. We don't always do that anymore. You can prevent it with allopurinol that reduces the uric acid production. You can treat it with rasburicase that directly breaks down uric acid. And then we manage electrolytes depending on what the derangement is. Sometimes patients will need dialysis. All right, I think that's it. Thank you very much.